Hi guys, this actual audio review is only going to cover chapter 15. It's just going to be the basics of fetal heart rate monitoring. The rest of it is on your module 1 blueprint from me. Jennifer has her own review, and if you complete that blueprint and review this audio video, you're going to do great on your test. All right, we're going to start with the basics of fetal heart rate monitoring. So what we have to remember that this top portion is always the baby or babies, and the bottom is the uterine contractions. So the little transducer that you put on the mom's fundus with a little button that as she has a contraction, it pushes that button. That's what these contractions are. And remember that it only shows us how long it lasts and how often they are. It won't tell us how strong it is. If it's this external, it is not really 50 millimeters. But it does tell us how long. Remember, each one of these little squares is 10 seconds. 10, 20, 30, 40, 50, 60. See, it's a minute for each one. Frequency, we count from the beginning, wherever the beginning falls, all the way to the beginning of the next for frequency. So we would go 1, 2, 3, 4, 5 minutes apart, and then we would count the duration, 10, 20, 30, 40, 50, 60, 70, 80, 90, 100 seconds is kind of a lengthy one. Now that just has to do with the mom's contractions. Now with strength, since this is an external monitor, we're not going to be able to give an accurate number. So we were going to say that it is either mild, it's moderate, or it's strong. And you're going to figure that pretty much by palpation. That's the only way you're going to know. And it's going to be push on the tip of your nose for mild, the tip of your chin for moderate, and your forehead for strong. Also, contraction duration, we don't usually want that to be over 90 seconds. For resting tone of the uterus, this is in between here. This is what you're going to see after the contraction has come back down, and that's going to be your resting tone. Again, you're not going to have an actual number that's accurate with an external monitor. It is going to be, again, soft, and you're going to have to palpate that to tell. Relaxation time is just the time between the contractions that allows the uterus to rest. 60 seconds or more in the first stage and 45 seconds or more in the second stage. And that's just kind of everything about the uterine contraction part of the fetal heart monitor. Now, if we do put in an internal monitor, it's going to be somewhat like a Foley catheter. It's a pressure catheter that lays up alongside the baby inside the uterus. And with those, we can get very accurate numbers, and we call those MVUs, Montevideo units. We're not going to really talk about how to calculate those, because you're not going to be responsible for calculating those. Just know that with the internal, I can have an actual number, and with an external, I have to palpate. So let's look at the fetal heart rate here. It's the one on the top. It says ultrasound there on the side. We have to know the baseline. What is a normal baseline? It's 110 to 160 beats per minute. In order to analyze that, you have to have at least 2 continuous minutes of a recording in a 10-minute period. And we don't include anything that's acceleration or deceleration, so we try to get right around the middle. We try to kind of draw an imaginary line, and we'd say that's about 140 beats per minute, because we don't count all the ups and all the downs. So that's the baseline. So variability is just the fluctuations in the fetal heart rate baseline. We don't count these accelerations and the little decelerations, but it's the beat to beat difference, the fluctuations, if you will. This is from your textbook. This figure is. So absent variability would be a straight line. There's no variability at all. That's very bad. Minimal would be less than or equal to 5 beats per minute, and that means it's less than or equal to 5 beats up or down. And absent or minimal is usually classified as abnormal or indeterminate, and it's going to depend on the other characteristics. Remember, we don't look at just the heart rate by itself. We look at the heart rate and all these different areas of the heart rate and compare it to what's going on with the contractions. So moderate variability, 6 to 25 beats per minute. 6 beats all the way up to 25, and that's up or down, and that's considered normal. And then marked is anything greater than 25 beats per minute, equal to or greater than 25. And usually that's considered unclear, but it's usually a normal variant as well. When we talk about sinusoidal, we're not talking about variability anymore. This is just a pattern in itself. It's a smooth, undulating, wave-like pattern that's uncommon, but we do see it with severe fetal anemia, fetal sepsis, chorioamnionitis, or if mom's getting opioid analgesics. And it's usually, like I said, it's rare and it's usually ominous. You do have to look at the variability as well as that pattern. You see this has very minimal variability and the sinusoidal pattern that combined makes it kind of a scary pattern. All right, this is tachycardia. This is a baseline fetal heart rate greater than 160 beats per minute for 10 minutes or longer. Remember that it has to be 10 minutes for it to be considered a baseline change. If it just lasted for 3 minutes, we wouldn't call it tachycardia, we'd call it an acceleration. So let's look at it. I'd say it's about 170 because it's pretty much on the line. Do you see the variability there? What would you call that? I'll call that minimal variability. So we get up a little high and the variability goes down. And those are some things that we can see. It can be an early sign of fetal hypoxemia if it's associated with late decelerations, minimal, which we have, variability. But there are other things that can cause it too. So a lot of times it's maternal or fetal infection, maternal hyperthyroidism, and sometimes it's in relation to meds such as terbutaline that we give them to stop having contractions. So that's important to remember those things. Nursing interventions are just solely going to depend on the reason. If we have an infection and we're running fever, we're going to give antipyretics, and we usually will go ahead and give these kiddos some oxygen, or mom some oxygen. Give the kids oxygen through mom, if you will. All right, for bradycardia, we're going to see a baseline fetal heart rate less than 110 per minute for a 10-minute period or longer. This is rare, but it's not specifically related to fetal oxygenation. We have to differentiate it, bradycardia, from a prolonged deceleration. Some of the things that could cause this would be structural defects with the infant, a viral infection, mom having hypoglycemia or hypothermia. Those can all cause it, and their intervention is again going to be based on what's causing it. All right, accelerations. This is an increase in fetal heart rate above baseline for at least 15 beats. So it's going to go up 15 beats and it's going to last 15 seconds. And this is with a return to baseline in less than 2 minutes. And this is considered an acceleration. If the baby's less than 32 weeks, it'll be more of a 10 up and 10 over, 10 by 10 acceleration. We have to remember again that anything more than 10 minutes is a baseline change, and that accelerations can be episodic, which means there's no relationship to a contraction like right here, or they can be periodic, which occur with a contraction. These are common with fetal movement, which is episodic, or with a contraction, periodic. We really like to see ACLs because they tell us that the fetus is doing well and that it has a normal fetal acid-base balance. Decelerations now are dominance of the parasympathetic response, but we categorize them according to when they begin and when they end and their shape. So the first one we're going to talk about is an early deceleration. Usually it's caused from transient fetal head compression. This is normal. There is no intervention necessary. The onset of the decel is identical to the onset of the contraction. They'll mirror each other with a smooth appearance. It can be caused by contractions, vaginal exam, fundal pressure, or placement of an internal monitor. There is no clinical significance and no nursing intervention needed. All right, a late deceleration. This deceleration begins after the contraction has started, and it doesn't recover until after the contraction is over. Some of the causes, it's a reflex fetal response to transient hypoxemia. Usually it's during a uterine contraction. We say that it's due to uteroplacental insufficiency, say maternal hypotension, uterine tachysystole, putting in an epidural, a placenta previa, placental abruption, post-term gestation, IUGR babies, diabetes, and infection in utero. We do consider this ominous, and it requires immediate intervention. We want to stop the Pitocin if it's infusing. We're going to change the position to a lateral position, oxygen to correct the maternal hypotension, and that's usually by mask at 10 liters, non-rebreather. Increase IV fluids. We're going to palpate that abdomen to see if it's got tachysystole. We're going to notify the physician, and we're going to consider internal monitoring and assist with delivery of this baby in whichever form and fashion it needs to be done. Remember, it's okay to be early, but it's never okay to be late. Variable decelerations. These decrease by 15 beats per minute below baseline for 15 seconds. They return to baseline within 2 minutes, but it's the shape that we're looking at. It's a U, V, or W shape, and it's a very rapid descent. It's not the smoothness that we see with the other decelerations. This is usually compression of the umbilical cord, and it can occur with or without contractions. Maternal position, nuchal cord, a short cord, a true knot, or a prolapse cord. And that's when the cord has come out, the baby's head has come up against it, and it is cutting off all of the blood supply. Interventions. We're going to stop the Pitocin. We're going to do change of position, maternal. We're going to give oxygen, notify the doctor, assist with vaginal exam to make sure that there's not a prolapsed cord. And with this particular, and this is the only one that you're really going to see amnio infusion ordered as an intervention, because that's the reason that we're having these decelerations, is because that cord is being compressed against mom's body parts. And if we do amnio infusion, we put that catheter in and we put fluid in, it's going to kind of help resolve some of that. And of course, we're going to assist with delivery if needed. Now, the last one we're going to talk about is a prolonged deceleration. And this is the fetal heart rate that has decelerated at least 15 beats below baseline, lasting more than 2 minutes but less than 10. Because remember, after 10 minutes, it's considered a baseline change. So this occurs when whatever was causing that late or variable decel to extend. Maternal apnea, cord compression, a stretch or a prolapse of that cord are all examples. Treatment. With all these, you're going to check the equipment and make sure that what we're looking at is really correct. Is it connected correctly? Check all the connections. We're going to prepare for internal monitoring. We're going to administer oxygen, again, non-rebreather, mask at 10 liters per minute. We're going to assist to a sideline position, increase the primary IV rate. It's going to be based on specific problems. After that, if we have Pitocin going, we're going to stop it. If it's a uterine tachysystole, we're going to give tocolytics. If they're pushing, we're going to encourage an open glottis pushing as opposed to a closed glottis pushing. And we're going to try to shorten those pushing efforts and let them kind of labor down. One of the terms that you need to remember is when we treat an abnormal fetal heart rate pattern, it's deemed intrauterine resuscitation. And look at the basic interventions on page 373. There's a box 15.8 to treat an abnormal fetal heart rate pattern, the basic interventions. I need you to check those out. And that's it for your fetal heart monitoring review. Thank you.